Good day. I'm John Kirkwood from the University of Pittsburgh, here to open the Great Debates in Melanoma, our second annual Great Debates, held in Phoenix, Arizona on the 22nd of November 2014, on behalf of myself and my co-organizer, Tony Rebus from UCLA. We have had a great turnout of many local and regional investigators and surgeons and medical oncologists, and it is a delight to be here to overview the results of this Great Debates for you today. But first, one of the things that has the greatest impact upon our patients, surveillance tests that we do to detect the presence or absence of disease, was a point of discussion, and I think there we actually saw interesting advocacy for a less aggressive pattern of surveillance argued by John Thompson, who on the NCCN panel spoke to the guidelines which really argue for less and less surveillance testing and certainly not the regular performance of CT scans, PET scans, biomarker assessments for our patients, and where they are to be performed, thought that these should be really confined to the highest risk groups, stage 3 and up, where the relapse risk plays out over a period of 2 or 3 years, and for brain disease, perhaps even over 24 months, arguing that after that, it makes no sense to do repetitive MRIs, repetitive CT scans, PET scans. On the other hand, Jen Wargo arguing from a surgical standpoint that earlier disease detection and our new modalities of therapy, 6 of them that we now have in the last couple of years to deploy against melanoma, have potentially greater effects, both for the targeted therapy and for the immunotherapy in earlier disease, arguing, of course, that detecting disease earlier may make sense. And so our vote in the audience actually weighed heavily to doing more surveillance, not less, I think much to my surprise. Dr. Rebus, what was your take on this?
I was also surprised that people were advocating for more surveillance, even though the data is against that, because most of the relapses are detected by patients themselves or partners as opposed to the more expensive and invasive scans. There was quite a bit of discussion about also the emotional impact of having to wait for scans. So that was, I think, a very interesting debate, and I'm sure we'll have to follow it the next time. You and I said this is a debate we have to continue having because we still haven't settled on it. So next we had a debate on adjuvant therapy between Dr. Kirkwood and Dr. Postow, who's from the Memorial Sloan Kettering in New York. It was a debate mostly focused on should we use high-dose interferon or should we use ipilimumab for adjuvant therapy. And there was a lot of data that came out, but I think the consensus was at the end is that we really need to wait for E1609. That is a study that will give us closure on this issue, because until then, I look at the data and I think I agree mostly with you, and maybe not that much with part of the audience, that high-dose interferon is our standard, and that the ipilimumab adjuvant trial in the ORTC with a 10 milligram per kilogram, I'm not impressed with the relapse-free survival, and I'm really impressed with the toxicities. So I think that interferon should continue to be the standard.
And I think for all of you listening in on this, we really have a new trial, SWOG-led 1404, which will test pembrolizumab at the approved dosage as adjuvant therapy. And this will be compared to our gold standard of high-dose interferon. It will allow us to ask the questions that really now need to be asked about third-generation immunotherapy with much less toxic pembrolizumab, greater efficacy, less toxicity, and I think the hope that we really have things that will continue to leapfrog forward and be the topic for our discussions in years to come, both in the Great Debates in Oxford next year and in Perspectives in Melanoma in September of next year.
So the next debate we had is a debate that I did with Dr. Tara Gendahar from Penn. And there was a debate about, so do we need to know BRAF status always when we decide treatment for a patient with advanced melanoma? I know you and I pushed the debates to the limit. We want the best arguments to come up. And it's obvious that we all would want to know more, and it's hard to sit in front of a patient and discuss treatment without knowing the BRAF status. But my point of saying that maybe we're getting closer to not needing that is because I think the field will bring us PD-1 and anti-PD-1 and anti-PD-L1 upfront. And it's not still not there yet. Obviously, the approval is on previously treated patients. But when it's approved on frontline therapy, I'll be very comfortable to discuss PD-1 therapy, anti-PD-1 therapy with patients, even if I still don't know the BRAF status, because what I'm going to be deciding, helping decide with that patient is, should you get to single-agent PD-1 or PD-L1 antibodies? And I think we'll use different assays for that.
And I think with PD-1 now being compared against dacarbazine in trial results that were just released in Europe at SMR, nivolumab versus dacarbazine handily beats our old reference standard of chemotherapy. And it's very likely that upfront anti-PD-1 will become an option for the community at large within the next year. The next debate, of course, was where to put interleukin-2, our first 1998 approval for treatment of metastatic disease with an immunotherapy, how to place this in relation to IPI, in relation to Pembro, in relation to potential other therapies that will be coming down the pike. And here, Mike Wong, I think, argued that the time that it takes to understand whether a patient will respond to interleukin-2 is really barely 6 weeks. That time, although it obliges a patient to 2 admissions for therapy, gives a very rapid turnaround. And I think the contrary argument that after new agents, and this is from Tara Gangdahar, that we basically should put interleukin-2, which requires much more for hospitalization after the newer therapies, was clearly a draw. I think clearly we may, for some patients, see the need to have quick response. There, interleukin-2 may be reasonable, but with pembrolizumab now we have rapid response from new and less hospitalization-intensive therapies, so that this is an evolving paradigm. The debate on the optimal schedule and duration of treatment with BRAF inhibitors, where continuous therapy was argued by Kim Margolin and intermittent by Alan Al-Ghazi, I think resolved that intermittent therapy is currently being tested in S1320, a trial which is now active and potentially available across the country as an intergroup effort. This is something that we can test, we should test, and that the trial option for patients with BRAF mutation would be the preference. But without that, I think we don't have data yet that allows us to say whether intermittent therapy or continuous therapy are superior one to the other.
This is the kind of debate that's really nice because it's based on very elegant preclinical data to think that intermittent therapy may have a value. It's based on studies in mice and studies in cell lines where the continuous exposure to the BRAF inhibitor blocking this pathway allows the melanoma to adapt to that and then escape through different ways. And the concept is that if you do that intermittently, then the melanoma will not be able to adapt that much and maybe will have more durable responses. And that was shown in mice, but our job is not to show it in humans. And we have the right clinical trial to do this, and it's chaired by Alan Al-Ghazi, the S1320. So I really look forward to seeing that study accruing well. It's a study where both arms get standard of care therapy. The agents are covered through the cooperative group mechanism. So it will be really looking forward to that moving forward. And the next debate was another interesting one. The question was a very bold question we posed to Jen Wargo, who's a surgeon from MD Anderson, and Alan Al-Ghazi, a medical oncologist from UCSF. And it's, are BRAF inhibitors immunotherapy? And Jen Wargo has done a lot of research in this field, and she's demonstrated that when you give a BRAF inhibitor, shortly after that, T cells infiltrate the tumors when they're responding. And at that point, there's increase in tumor antigen presentation in melanosomal antigen presentation, all of which suggests that there may be some immune effects. But Alan Al-Ghazi made the counterpoint, said, well, that may be there, but that's not enough to have the hallmarks of immunotherapy, which is have durable responses once you engage the immune system, because the immune system has memory. And here I don't think we see much of a memory phenotype. So I think that there was a debate where both made very good points, but the clinical outcome of patients, to me, suggests that BRAF inhibitors may not cripple immunotherapy, but I don't think by themselves are immunotherapy.
And the following debate was the role of one of the oldest therapies, one of the most intensive, intensive and patient toxicity intensive therapies with adoptive tumor infiltrating lymphocyte therapy, which in the NCI, in the surgery branch, has been a highly effective therapy for a very select number of patients with responses that may be over 50%, but costs that are really probably untenable in the community, and where the question of whether TIL therapy now is to be considered as a recourse off protocol for patients. I think the argument that TIL therapy has a role from Raghi Kudikchar was that this is an effective therapy, and like PD-1, like anti-CTLA-4, like IL-2, should be considered as an additional option for patients to gain the most from immunotherapy. I think the alternative from Mike Wong is that this is terribly costly, has never been supported in a randomized trial as better than any comparator, and really has yet to be established in its place overall. I think for everyone to realize a multi-center study in Europe is going to go on, which may test this finally against ipilimumab, and we'll have to wait to see how that plays out.
Yeah, that's going to be really interesting to see a study like that. So the next debate that we had was a debate on in-transit disease. So we have this new generation of injectables that are being tested in this subpopulation. It's a very distinct course in these patients. And Robert Ambaka, who's a surgeon from the Huntsman Institute in Salt Lake City, was making the point that different agents, T-VEC, vaccinia, which is a modified herpes virus, a vaccinia virus, rose bengal, or CpG oligonucleotides, when injected inside tumors, can lead to a local response, and that can also lead to a systemic response and be able to shrink lesions that were not injected. We only have one randomized trial there, which is the T-VEC clinical trial that was compared to GM-CSF given systemically, and Kim Margolin, who's from now at Stanford, before was at the Fred Hutch in Seattle, made the argument that the control arm of the randomized trial, which is positive for the injectable T-VEC as opposed to the giving GM-CSF, was that the GM-CSF is not our standard, and that the response, that the population of patients being treated in that study were not the regular patient population with advanced melanoma. But I think leaves little doubt that injecting some lesions, you can get local responses and then some responses in other sites. And I look forward to building on these, because we're starting to see the data from combining these agents with checkpoint inhibitors, both ipilimumab and hopefully pretty soon PD-1 antibodies. I think that would allow us to move forward from these, and I think it's going to be my personal feeling is going to be that it's going to be both that we're going to be using in the near future.
Yeah, clearly these add a new dimension, and I think, like vaccines, how to couple them with the non-specific immunotherapies that we have with anti-PD-1, anti-CTLA-4, even with interleukin-2, is really a question that begs to be asked. And so the following debate was how should we deploy the anti-PD-1 modality? Should it be given alone, which you argued, or should it be given in combination with ipilimumab anti-CTLA-4, which Mike Posto from Memorial argued? Clearly, the arguments for the combination are the rapidity of the responses, the independence of PD-L1 expression and other biomarkers, the fact that so-called deep responses are seen, which may eclipse the responses seen from single-agent PD-1. But clearly, he admitted the toxicity for this therapy with CTLA-4 added to PD-1 is much greater. And I think in the end, the biggest argument may be that a complete response rate well over 10% is seen with the combination where we don't see complete responses so frequently with PD-1 alone, either Nivo alone or pembrolizumab alone. And I think ultimately biologic questions about the immunologic response engendered by CTLA-4 and by PD-1 therapy need to be asked, and they're still being asked, so that we don't know the fundamental basis for answering this question.
So the next debate was a debate about the correlation, or the potential correlation between progression-free survival and overall survival in immunotherapy trials of melanoma. I think it's very easy to think that for targeted therapies, if you have an impact on progression-free survival, that's the linearity with overall survival is quite there, at least in the clinical trials we've seen so far. And you made the argument that based on the data that was published recently on a meta-analysis by Keith Flaherty and colleagues that was published in Lancet Oncology, that the same observation for targeted therapies was maintained for immunotherapies that were studied in there, in particular with ipilimumab, even though we know that the effect on progression-free survival seems to underestimate the overall survival that we're seeing in these studies. It's Alan Bryce, who's a medical oncologist from Mayo Scottsdale here in Arizona, made the counter argument about this, and he brought, I think, a very valid point, which is the concept of post-progression therapy and how is that impacting on overall survival assessment. That was not when we had one of the clinical trials that we had so far, because now with several active agents approved, and particularly having active agents that have different mechanism of action, immunotherapy or targeted therapy, you can have an immunotherapy randomized trial and have PFS or not, but then when you look for overall survival, you may have a targeted therapy tested post-progression, and that for sure is going to be altering the results of the initial study that you're following. So it's something that looking backward, his point I think was that looking backwards, it was pretty clear that PFS and OS correlated well, but looking forward, we're going to have trouble, and it's going to be difficult to have studies looking only of overall survival in the metastatic disease, because there's going to be active agents post-progression.
Yeah, I think the argument that post-progression survival is a completely new arena where a year or maybe even 2 years post-progression will be seen, where in times past, weeks, maybe a month or two would be the only time anticipated post-progression before death would ensue, really has changed the ballpark. I think the counter-argument, of course, is that one could take second progression as an endpoint for new trials where we're thinking for the patient, what is the best strategy overall? New trials such as EA6134, Mike Atkins will lead testing the doublet of BRAF plus MEK inhibitor, and the doublet of Nivo and ipilimumab will test one or the other first on a randomized basis and allow us to get to some of these questions as well. But I think it's a new arena, and I think for sure what he argued about a moral imperative to think about overall survival as the major goal for patients, none of us dispute. I think we all want to see survival improve for patients in the end. And we've seen the FDA insist in new trials, for instance, the pembrolizumab versus interferon trial, the FDA insists only survival is a primary endpoint. So I think the argument is really one to bring out the points, but we all agree upon the fundamental points here. The next argument, or the next debate, I should say, not an argument, was whether anti-tumor activity of our immunotherapies should be considered on the basis of immune response modified criteria built out of the old WHO bidimensional measurements, or on the simpler, more recent, and perhaps stiffer requirements of RECIST. I think there, Peter Cohen argued that IRRC might be more sensitive, pick up changes that wouldn't be picked up by RECIST criteria, but you argued, I think, very effectively that RECIST and IRRC have remarkably similar readouts in regard to our newest category of agents, pembrolizumab, where that argument that there is so little difference with the newest agents, to me, was compelling. And I think RECIST, which probably our regulatory authorities will accept alone, is really what we're going to see as the default pattern of assessment for the future. And so I think, in overview, we had a very productive debate in our second annual Great Debates in Melanoma. It was one which I think brought up the questions that we need to address for the future, and probably in Oxford next year, issues that relate to brain metastasis, as well as those issues that we haven't solved this year in regard to surveillance criteria for adjuvant therapy assessment, will all come to bear. And I think it's a very fertile time in the field, one which is bringing many new questions to the front, almost as many as we have new agents to throw at the disease.
I think this format that we've had with the great debates it brings up a lot of good arguments, and the feedback from coming out of the room was very positive, I think, on the format. We also have our other melanoma meeting that we co-organize, which is the Perspectives in Melanoma, that for the year 2015 is going to be in Cleveland. We're excited to go to that part of the country. There's we have a local organizing committee that's very engaged, and we look forward to that meeting also.